Good day and welcome to the Workforce Safety for Syringe Service Programs webinar. Today's conference is being recorded. At this time, I'd like to turn the conference over to Sarah Hashmal. Please go ahead.
Hello everybody. Thank you so much for joining today's webinar. We're so happy to have you all on the line. As we just learned, this webinar is being recorded, so it will be available on AIDS United's website after this recording for yourself or any colleagues who want to reference it after the fact. This webinar is in listen-only mode. If you have any questions, please use the little blue chat icon on the bottom left of your screen to get in touch with us. I'm going to turn it over to Adrienne Neal to get us started.
Hi, good afternoon everyone, or good morning depending on where you are located. As Sarah stated, my name is Adrienne Neal Jr. and I'm a Capacity Building Specialist with AIDS United here within our Getting to Zero program. On behalf of AIDS United, we want to welcome you to this webinar. I will take a brief moment to go ahead and introduce our presenters for today. The first one I will be introducing is Joanna Martinez. She could not be with us today, but she definitely contributed many materials and content to this webinar, so we just want to make sure she's recognized in this space for her efforts. The next person I will introduce is Emma Roberts. Emma Roberts has worked for the Harm Reduction Coalition as a training consultant since 2009. And in 2014 was hired on as a full-time staff. Today, Emma is the Director of Capacity Building Services. Her focus is to provide technical assistance and support to programs promoting syringe access, drug user health, hepatitis C services, and overdose prevention. Emma, thank you so much for being a presenter on today's webinar. The next person I'll be introducing is Haley Cole. Haley is the Director of the Sonora Prevention Works organization. Haley was born and raised in Phoenix, Arizona, and is the founder and executive director of Sonora Prevention Works. She has worked and volunteered as a syringe access programs in Phoenix and Tacoma, Washington since 2011. She has built programs for health insurance navigation, hepatitis C testing, and syringe access, as well as naloxone distribution in rural and urban areas. She is also dedicated to culture and policy change throughout Arizona to achieve health equity for people marginalized by the war on drugs, white supremacy, and capitalism. Again, I want to thank all of our presenters for being on this webinar today. And next I'll be going over a little bit about the capacity building program here at AIDS United. So here at AIDS United, we have a capacity building program called Getting to Zero. And overall or general information about AIDS United, we have a few pillars that we pride ourselves on. That's capacity building, strategic grant marketing, formative research, and policy and advocacy. Each of those are things that AIDS United does as it relates to the community, nationally and locally. The Getting to Zero SIBA program, we strengthen HIV prevention efforts among people living with HIV and at high risk for contracting HIV. Organizational and program development best practices to improve impact and sustainability, and evidence-based interventions such as Willow, Project Start Plus, and healthy relationships. In a nutshell, the Getting to Zero program here at AIDS United develops and implements trainings to help build the capacity of organizations across the country. The next person you will hear is Emma Roberts to talk about the Harm Reduction Coalition.
Thank you, Adrienne. Happy Monday, everyone. It's so good to be with you today. As Adrienne said, I'm the Director of Capacity Building Services here at the Harm Reduction Coalition. We have two offices. We are based in New York and we have an office in Oakland. And we provide services across the United States. We were set up in the early 90s by a group of people who use drugs, their allies, their loved ones, and advocates that wanted to support challenging the stigma related to people who use drugs and promoting respect and dignity for them and access to the services that they have a right to access to. Our work is split out into the various areas you can see on this screen. So we have a policy and advocacy team that work at the federal, state and local levels to promote policies and advocacy relating to harm reduction and syringe service programming. I'm a part of the training and capacity building team, and we provide trainings and technical assistance across the country to organizations, including community-based organizations and health departments that are looking to provide harm reduction programming and develop syringe service programs. We also have a dedicated team that works on overdose prevention and advocacy. So that includes things like increasing access to naloxone for people, and also they are doing a lot of work on the expansion of access to buprenorphine at the moment. We also host national and regional conferences. I'll tell you a little bit about we have a national conference coming up in New Orleans in October, so please visit our website to access more information about registering for that. And that's a great opportunity for people to come together to explore lots of different facets relating to harm reduction and get lots of support if you're developing programming. And then you can actually go to our website, harmreduction.org, to access a whole range of publications and resources. Some of our other pre-recorded webinars are on there too, so please feel free to go there. And most recently, we've added to our mission statement, we've added the North Star statement that you can see that's written below those boxes that says, Harm Reduction Coalition creates spaces for dialogue and action to help heal the harms caused by racialized drug policies, because we want to keep at the forefront of the work we do the recognition that there are individuals and communities of color that have been most punitively impacted by the war on drugs. So that's a key part of the work that we do, and we want to recognize that. And then I'm just going to quickly hand over to Haley so she can tell you a little bit more about Sonoran Prevention Works.
Hi, everybody. This is Haley from Sonoran Prevention Works. We are an Arizona-based organization focused on the unique challenges of implementing harm reduction here in Arizona. We provide direct outreach, on-the-ground services. We also provide technical assistance and capacity building assistance to agencies within the state who engage with people who use drugs. And then we also work on policy to ensure that our local and state laws are supportive of harm reduction measures. We work with all of the syringe services programs here in the state who are all officially unsanctioned because of our state law, but we ensure that we do everything we can to make sure they have what they need and that our policies support them. So I'm going to turn it back over.
Thank you, Haley. So just to outline the goal of today's webinar, what we're looking to do is promote best practices for workforce safety, and this includes compliance to the Occupational Safety and Health Act, or OSHA, as it's commonly known, among community-based organizations that are both directly and indirectly funded by the CDC to implement HIV prevention services, including syringe service programs. I also want to recognize that we probably have people on the call as well that are calling in from health departments and other community-based organizations. So we want to welcome everyone on this call because we know that syringe service programs are becoming more prominent and more available across the country. So welcome to everyone that's joining us. So the webinar is going to be for 90 minutes, and we're going to have a little time for Q&A at the end. And one of the particular reasons for holding this webinar is because we wanted to address skills building for the syringe service program workforce that is growing, to provide them with the relevant resources and tools that they can adapt to address their needs in a range of different geographical areas and resource areas. To also be in line with one of the first goals of the Division of HIV and AIDS Prevention, or DHAP, which is about the prevention of new HIV infections. So we want to provide the workforce with the tools to keep themselves safe whilst they are working to meet the goals of reducing HIV infections amongst people who inject drugs. And then the key learning objectives for today are, hopefully by the end of this session, you'll be able to identify the bloodborne pathogens that to prevent during syringe service program delivery, to identify measures that a syringe service program can put in place for workforce safety, and describe some of the harm reduction strategies to reduce exposure to bloodborne pathogens. And then just a glossary of terms that you'll see come up regularly when we're talking about this work. So an ECP speaks to an exposure control plan, and we'll be looking at those in a little bit more detail soon. OPIM relates to other potential infectious materials. So there's a range of potentially infectious materials that we might come into contact with, not just syringes when we're working on syringe service programs. And as part of protecting ourselves, we might need PPE, which is personal protective equipment. We also use terms like PWID and PWUD, which stands for people who inject drugs and people who use drugs. You may also see in other places the term IDU, injection drug user. We moved away from that terminology to use person first language because we feel that that is more respectful to people who use drugs, to see them as people first. In the same way that we use person first language when we're talking about people living with HIV and AIDS, and we use the acronym PLWHA for that. You'll also see a variety of different acronyms related to syringe access or syringe service programs. So here we have Syringe Access Services, SES, and Syringe Service Programs. You may also see NEX, Needle Exchange Program. These are used in different places across the country. The reason we've moved more towards using the term Syringe Service Program is because we want to capture the range of services that harm reduction and syringe service programs provide. They don't just give out needles, they don't just exchange needles, they provide access to needles, they provide access to a whole host of other materials for safer drug use, safer sex, and also a range of services and referrals and linkages to care for people, including linkages to treatment, HIV treatment and hepatitis C treatment, and overdose prevention resources, including naloxone. So we've moved to using this terminology, but if you use a different terminology where you are, that's fine, but that's just an explanation of why we're using this as an umbrella term to capture all of those services that we provide. And then just a quick outline of the webinar. So we're going to look at through the rest of the time, the effective intervention of syringe service programs, why we have them, why there's a need for them, and why they're a good idea. We're then going to look at bloodborne pathogens as a prevention, as what we need to prevent coming into contact with, and what to do if that does unfortunately happen. We're also going to, as part of that, outline the OSHA and universal precautions measures, and look at building exposure control plans and instituting accidental needle stick protocols. And then we're going to summarize at the end with a look at harm reduction and best practices for syringe service programs. And then we'll have time for Q&A at the end, as I said. So jumping into syringe service programs. I'm sorry, I seem to have lost my view of the slides. Hold on. Yes, I will. It's okay. I have them in front of me. When we're talking about syringe service programming, we're talking about access to sterile needles and syringes. We're also talking about safe disposal of those syringes and other substance use materials that people might need. And as I said just before, we're also talking about providing referrals to treatment, overdose education, access to hepatitis A and B vaccinations, which are particularly important for folks that are injecting drugs, especially those that may already be living with hepatitis C and have not been able to access treatment yet. And also HIV and hepatitis C prevention services, testing, and linkage to care. So in terms of the need for syringe service programs, we've got research that shows that among people who inject drugs, at least 1 in 4 from the research that's been done have talked about sharing injection equipment in the last 12 months. So it's really important that we provide sterile and new injection equipment to people so that we reduce the likelihood of them having to share someone else's syringes and other materials that they need to use their drugs, such as cookers and cottons and water. And then also, people who use drugs are also found to be perform the majority of overdose reversals that happen. So in recognition of that, our services provide the education that they might need if they are with someone that's overdosing, and also access to the naloxone that they need to then carry out a reversal. We've been able to effectively show that this is an evidence-based intervention for people who use drugs that's been, demonstrated over a significant number of years. And then some of the key benefits of syringe service programs. So as I mentioned, we are working to prevent HIV transmission and engage people who are already living with HIV into care as well, especially if they come into the syringe service program and they're disconnected from care or haven't started HIV treatment yet. We can get them connected to those services. We want to prevent hepatitis B and reduce the transmission of hepatitis C, and get naloxone into the hands of people who are most likely to be on the scene in order to reverse an opiate overdose. And the evidence shows that people who come to syringe services are more likely to be linked to care and treatment, including drug treatment, and also linkage to HIV care, than people who are using drugs that aren't accessing syringe service programs. So we have some good solid research to show that is the case in terms of the benefits that syringe service programs provide. And just a word in terms of the federal funding guidelines. For many years, we weren't allowed to access federal funds to support syringe service or syringe access programming. But in 2016, there was a change to those guidelines through the Consolidated Appropriations Act. And basically what that now tells us is that we can use federal funds for all those items that you see on the left-hand side of the screen. So for staffing, for the supplies, for testing kits, for the building that you're in or the vehicle that you use to do mobile outreach, for a whole range of other materials. The only thing that we can't currently use federal funds for is the purchase of the sterile syringes and needles themselves. But, someone who ran a syringe service program in New York City, the cost of the syringes was the smallest part of my budget. So it's great that we now have greater access to federal funding for the work that we need to do.
Hi, Emma. Real quickly, before we move forward, we kind of want to go over some of the poll questions that were asked. So we're going to do that for a brief moment.
So many of you already answered one of the polls that's up. So just to give us an idea of who's on the call, of does your organization provide or partner with organizations to provide HIV services, syringe services, both, or neither? Most of the folks on the call here are providing both. Next, if you want to let us know how long your syringe service program has been in operation. If you haven't started yet, less than 2 years or more than 2 years. So looks like some answers are coming in, and this just helps us inform where to target the information on this webinar to see where folks are at. We've got a big spread here with, let's see, right now we got about 40% haven't started yet. A third and a third, maybe less than 2 years, more than 2 years. So this is really exciting, actually, to have such a broad spread of folks, including such a large number of folks who haven't started yet and are looking to get all the info before they get going. So this is really very exciting.
Yes.
Thank you, guys. Thanks for the reminder about the poll. Yeah, it's so good to have so many of you on the call that have recently developed syringe service programs in, I'm sure that they're in much needed areas of the country, so it's great to hear that. So, for those of you that are working at community-based organizations, we hope that the information we're going to present is really helpful to you in terms of really being mindful of how you develop your protocols around workforce safety in relation to this. So then we'll move into part 2, where we're beginning to look at bloodborne pathogens, and Haley is going to take that section.
Thanks, Emma. So in this section, we're going to talk about what a bloodborne pathogen is. We'll identify some of the bloodborne pathogens that can be prevented during SSP delivery, and then we'll talk about specific instances where an exposure could occur at a syringe services program. So in talking about bloodborne pathogens, we're talking about viruses, bacteria, other microorganisms that are present in human blood or in other potentially infectious materials and can cause diseases in humans. These pathogens are spread when the bodily fluids of a person living with the pathogen enters the bloodstream of another person. So for the purposes of this webinar, we're talking about body fluids that visibly have contaminated blood in them, like vomit or urine, and all body fluids in situations where it may be difficult to distinguish between the combinations of bodily fluids. And of course, this webinar is focusing specifically on the potential exposures that could occur at a syringe service program. So if we were discussing safety measures for hospital staff or a dentist's office, we would include other practical measures to keep that workforce as safe as possible. So we are talking specifically about syringe service programs and our safety measures. So some of the common bloodborne pathogens we may see at syringe services programs are going to be HIV, hepatitis B, hepatitis C, and syphilis. Some of the bodily fluids that we may see include semen, vaginal secretions, blood, including menstrual blood. I've certainly been present at an SSP when people dumped condoms and God knows what else into the sharps container. So it could be possible to have contact with any of these bodily fluids, but most commonly at an SSP, the bodily fluid that could come into contact with a person is going to be blood, and the transmission route will most likely be an accidental needle stick. So an accidental needle stick would occur when somebody's used syringe will accidentally poke or scrape the skin of somebody else, resulting in an accidental exposure. Another consideration for syringe service programs is on-site restrooms and cleaning up of blood spills if we come into contact with a blood spill, whether it's in the restroom or anywhere else around the program. So if the blood of another person contains a bloodborne pathogen and the person cleaning up that blood spill has a cut on their hand, that can also result in a potential accidental exposure. So it is really important that we note that accidental needle sticks are very low in occurrence at syringe services programs. And with proper training, the likelihood for an accidental stick at the work site significantly reduces. But we do want everybody to know about these risks so that you can implement these safety measures effectively. And we're going to give you the tools so that if an accidental needle stick does occur, you'll know exactly what to do and how to handle it. So after this section, we're going to talk about OSHA, developing an exposure control plan, and detailed protocols for keeping everybody at the SSP safe. But safety measures can be implemented immediately. They're pretty simple. We can have a conversation with new staff and volunteers as soon as they come on board, or we can have a more in-depth discussion and planning session every 6 months, every year, etc. But we do want you all to know that these safety measures can be implemented quickly, effectively, and can meet your program where it's at. So I'm going to turn it back over to Emma.
Thanks, Haley. So I'm going to take us through the next couple of sections. So this section is talking about OSHA and universal precautions. So as I said earlier, OSHA stands for the Occupational Safety Health Administration, which is a department of the U.S. Department of Labor, and it was created. It has created a bloodborne pathogen standard designed to protect at-risk workers from exposure of blood or other potentially infectious materials. And it also, as part of that, incorporated the Needle Stick Prevention Act of 2000. So these are the things that guide us as we're looking at workforce safety at syringe service programs. So in terms of the bloodborne pathogen standard, what that says is that employees and healthcare workers are covered by the standard and include those that have direct patient or resident contact, that may draw blood, that work with blood or other bodily fluids or specimens. They may handle contaminated equipment and biohazardous or infectious waste, and they may be responsible for cleaning up blood spills or blood byproducts. So, just for ourselves to note that, the program needs of someone working in a hospital, for example, will be different from those of people working at a syringe service program. But it's really important that when someone is hired at the syringe service program that we tell them about the bloodborne pathogen standards and how it applies specifically to syringe service program operations, including during onboarding, but also, to revisit this at a regular basis, and we'll be talking a bit more about this through the next slides. So when we talk about universal precautions, what we're talking about is an approach to infection control to treat all human blood and certain human fluids as if they were known to be infectious for HIV, HBV, and other bloodborne pathogens. Even if we are not sure, we're going to treat them as potentially infectious when we're working on the syringe service programs. And then when we're talking about sharps in relation to potential risks, sharps is a medical term for devices with sharp points or edges that can puncture or cut the skin. So on a syringe service program, this would typically be a syringe or a needle, but it can also be related to other materials that might be related to someone's drug use. So they may also include lancets or auto-injectors. So when we're talking about used sharps, we're talking about when the device has been used and is no longer new or sterile. And we're going to apply universal precautions by acting as if the used sharp has been infected, even if we're not sure or not. So for a bit more detail for syringe service programs, we're going to be applying universal precautions for any unknown sharp that's been used. And that might also include an individual syringe that perhaps is found outside of a new box or outside of a sealed bag. We might think it's not been used, but we're not going to treat it that way. We're going to treat it as a potentially used sharp and dispose of in the same way. And even if you can see a needle or a sharp that you can't actually see the blood on it, we're still going to treat that as a potential hazardous sharp and dispose of it along with everything else in the same way. So just to reaffirm that, if a syringe is found, we should act as if it has been used and apply the universal precautions when we dispose of it. And then just to talk about the guidelines for proper disposal. When we come across a used sharp, we are going to locate our sharps container at the syringe service program, make sure that the lid is open and it's accessible, and then as a member of staff we should have access to gloves, which could be nitrile, latex or vinyl, and then we would pick up the syringe by the barrel. Now in some places in the US the requirements are that we should also use tongs. But if that's not, the requirement, we can, as long as we have full use of our, we're fully dexterous in the use of our hands, we can safely pick up a syringe with gloves on using the barrel, and that would keep our fingers away from the sharp point. But if you need to use tongs, then you would also use tongs. And then you would drop that needle point down and close the lid and dispose of your gloves in the trash and wash your hands. So those are the guidelines that we're given for proper disposal on syringe service programs. And the next slide shows you an infographic that's useful, to help educate communities about disposal. You will also notice that the hand in this picture does not have a glove on it, but as I said earlier, for those of us working at syringe service programs, we should have access to gloves, and our programs should be providing those for us. And then just a little bit about the sharps container and safety around that. All sharps, syringe service program sharps containers should be made of heavy-duty plastic. They're usually of a bright colour. The ones I used on my program were red and were marked as biohazard. And then they should also have a lid that is leak resistant, and we should be able to close the lid. It should be tight-fitting without the sharps being able to come out. They usually have a flap or a door that gives you access once the main lid is in place, and they should be kept upright and stable during use. So especially when we're out on mobile provision, for example, we want to find places where they're not going to be tripped over, they're not going to be knocked over, they're kept at a height that provides easy access to drop them, the syringes in safely. And they need to be properly labelled and colour-coded and locked down and secured and unopened when they become 3/4 full. So that's another important aspect that I know I've had to talk to staff on the syringe exchange programs that I've supervised, is make sure that you're not overfilling the syringe buckets, that they're 3/4 full, and then we seal them ready to be sent away for disposal. And just an example for the field, I worked on mobile syringe service programming, so it's important that when we're doing that, we do take extra care to secure the sharps containers during transport. So my experience is that we've had, plenty of the special bungee cords that you can actually strap the containers down to stop them from falling over during transit. Or you might have a vehicle that's been specially adapted and has a specific space to actually put the syringe disposal containers into, so that they're kept secure and won't fall, to prevent them, from accidentally opening and needles from spilling out. So it's just something to be mindful, especially when you're doing vehicle-based syringe services. And then also, just to remind staff that once the perimeter of the lid for a sharps container has been secured on all 4 sides, that we should not try to remove it, as it's really hard plastic, and that can actually, put you at danger of becoming sustaining a cut on your hand and creating an accidental bodily opening. So again, we don't want to have people doing that. But I've had staff that have accidentally closed a syringe container and then thought they could try and take the lid off, but we just don't want people to do that. As I said, there should usually be a small opening in the syringe disposal container that you can still access once the main lid has been attached. And then the next tip is to never handle another person's sharp container. I think it's really common as humans that when someone offers us something, we might reach out to accept it. So commonly on the syringe service program, I've seen this happen in my experience, is that our participants will arrive and they'll want to hand you the containers that they've brought their syringes in, and sometimes that could be a plastic bag, it could be a cardboard box, it could be a soda bottle. So we want to encourage our participants to actually place their own syringes into the sharps container and not have staff accept them. So again, it's a really important thing to continually remind ourselves that we shouldn't be handling other people's containers in order to prevent needle sticks. And then we also try and discourage our program participants from transporting their used sharps in a plastic or paper bag. It does happen, but as much as possible we want to educate our participants on the best way to bring their syringes to the program, especially if they're not able to take away some of the smaller sharps containers that many syringe service programs do provide. There's a number of reasons why people might not want to take them. They might be too conspicuous, they might be homeless, they're not able to carry them. So we give them other opportunities. We used to talk to our participants about putting them into plastic bottles, but particularly the tougher bottles like bleach containers or washing detergent containers. We did at one time suggest that they use the soda or water bottles, but that became problematic because the plastic on those containers has got thinner over time, and I did actually have a staff member who sustained a needle stick injury as a result of an uncapped needle poking through one of those, a large soda bottle. So we try and educate our folks to try and use alternative containers, but if they do bring them in those, what we tend to do is have them dispose of those bottles themselves into another sharps container. We don't keep them out. We put them inside. At my exchange, it was the big, large red container. to give an extra level of protection to folks. And then just to speak about other potentially infectious materials, so for syringe exchange programs, and I think Haley kicked us off with this a little earlier, there's other potentially infectious materials that we can come into contact with, including human bodily fluids, so semen, vaginal secretions, any bodily fluid that is contaminated with blood. So we might be accepting materials that contain those kind of other potentially infectious materials, so we might need to help people dispose of those things as well themselves and not have staff come into contact with those. So some further examples would be, used, say, for injection supplies, including alcohol wipes, which may have blood on them, band-aids, tourniquets, cotton filters, wound care dressings, condoms or tampons that people might come across during outreach. And also if there's a blood spill on the bathroom floor or a surface area of used sharps container, they may, have other bodily fluids and blood on there. So we want to, again, have access to things that keep people safe, including gloves. So again, we want people to use gloves and then to pick up any material and dispose of it in a trash container with a plastic liner. And if we're on mobile outreach, we want to use a bag or a glove in place, a bag in place of a glove and dispose of these things in the trash, and then make sure people have access to wash their hands. Again, this can be something that on mobile outreach we don't have ready access. We might want to think about when we're on our outreach routes, where do we have access to wash our hands when we're out and about. And then just a note, an example from the field, one of the things that really galvanized syringe service programming across the US and made it the issue that we're talking about today become more of a need for people to learn about was the HIV outbreak in rural Indiana in 2015, where we saw over 200 people in that outbreak at the time infected with HIV, and a significant number of those people were also co-infected with hepatitis C. And that's we've worked a lot with people in Indiana and the surrounding regions to develop syringe service programming, and it's been a real kind of an inspiration to see people's response and how they've addressed the issue. And part of that has been helping them to develop their protocols around workforce safety. So for the next section, I'm just going to take us through some key elements when it comes to building your exposure control plan and accidental needle stick protocols. ECP, exposure control plan, is a written description of the safety measures to use at a work site to prevent bloodborne pathogen transmission, and it's basically your procedures to follow if an exposure controls. A key benefit of the ECP is to help organizations reach the goal to eliminate or minimize exposure to bloodborne pathogens in the workplace. As Haley said earlier, it's very rare. It can happen, but we want to put in place those measures to make sure that we minimize. And some of the key elements of your exposure control plan is that it must be written specifically for each facility. So you want to think about, if you're out there and you're doing building-based syringe service programming, you'll have a particular exposure control plan for that provision, which might look different to the exposure control plan that you would have for your mobile syringe service program. What we want to do is we want to review it and update it at least on an annual basis. So an example from my program was that when we sustained a needle stick through a soda bottle, we actually changed our exposure control planning and our needle stick prevention protocols to include wording that addressed that issue and how we would handle that moving forward. But we want to be reviewing it on a yearly basis to make any updates that we might need. We want it to be readily available for all staff. So, for example, on my syringe exchange program, we actually had the needle stick protocols up in the vehicle, so that if it happened, people knew exactly where to go and read it versus having to find it in a binder somewhere or, in a folder. Because in a stressful situation like that, people are already experiencing stress and anxiety about what's happened, so we want them to be able to have very quick and ready access to the information that they need to address the situation at hand. And we want to regularly educate workers on the uses of the exposure control plan and where it's available, not just when we onboard them. We need to revisit it on a regular basis. And then just in terms of a few more specific elements of when we're building an exposure control plan and what we want to include, we want to list the job types that could be present at an exposure and how that might relate to risk factors. We want to explain how to prevent those exposures. We want to list all the protective equipment and supplies that workers have access to. We want to describe where they're located so that people know where to find them easily and quickly. We want to identify where the used sharps containers are stored and how they should be secured. We want to post hepatitis B vaccination availability. I'll talk a little bit more about that in a moment. And we want people to know the procedures if someone is accidentally stuck. So as I said earlier, we had HOWAs posted up at all times so that people had access to them immediately if it happened. And then we want to have, a training topic checklist, especially for new workers, so that we can make sure that they have a good onboarding in terms of these safety protocols. And just then to add to that, some best practices for implementing your exposure control plan for workers. We want them, to be well trained so that they can put the ECP safety measures in practice, so as to minimise or eliminate any possibility of workforce exposures. And then for supervisors, we were responsible for ensuring that the exposure control plan is followed and provisions are made available to the workforce. So that might include providing a copy of the program's ECP as part of someone's orientation. We want to enforce its compliance. So as a supervisor, I would do regular site visits to the different sites. And as part of my visits, it would be, making sure that the best practices as part of the ECP were being implemented. We want to ensure that, as I said, new workers are properly trained, but that also existing staff, do a review each year, and making sure that the safety supplies and the biohazardous disposal materials are regularly in place, that they're in stock, that they, are part of our, when we order all our supplies, that they are routinely ordered along with everything else. And we want to perform follow-up procedures if there is an exposure, and I'll talk a little bit more about that in a moment. As I said, I was going to say a little bit more about Hep B vaccination. So we want to make sure that our staff have access at no cost to them as a worker to the Hep B vaccine series. And if a person does opt out or has to opt out for any reason, then we would ask them to sign a form to say that they declined that and they're aware of the risks. But then if they ultimately change their mind or their circumstances change, that they can then be vaccinated, that we help them to access those vaccinations. And then just a little bit more about personal protective equipment. These are usually at the syringe exchange programs come in the form of different kinds of gloves, so we can have access to nitrile, latex and vinyl gloves. Have a couple of choices because some people are allergic, but also making sure you've got a range of sizes as well. And then also we have access to puncture resistant gloves that are readily available for syringe exchange programs for people to use. And then just another quick tip. If your syringe service program is not able to provide the Hep B vaccinations themselves on site, making sure that our staff know where to go and that you have a relationship with a nearby clinic or a registered nurse so that they can go and get the vaccinations that they need, even if we don't have them available. And I think that's especially important for community-based organisations that might not readily have those on site or access to those. And then just a bit more about other safety equipment. We've already talked about the sharps containers, but also having access to the thick, large red plastic liners that are also used for biohazard, plastic bags for regular trash, also maybe access to bleach if we need to bleach and also deal with spills, paper towels, finger cots and band-aids are important for people. If they have little cuts on their fingers, they can cover them up with a band-aid and also wear a finger cot while they're working, and then also tongs. And as I said, some states require the use of tongs, which can be really useful, especially if you're finding syringes, if you're out and about and you're doing a sweep, in the community, and there's, you can see syringes that are under a dumpster or under bushes, and you want to, get them out safely. Tongs can be really useful. Sometimes in some programs in some states you have to use the tongs to then put them into the sharps container. But if your hands have full dexterity, it is also safe to pick them up by the barrel as long as you're picking them up away from the sharp end and then, as I said earlier, dropping them point down into your sharps container. I already spoke about this tip, so making sure that we have access to band-aids and finger cots for people if they do. Staff do have little cuts on their hands and fingers whilst they're working. And then just another example from the field. So if you're doing community needle sweeps, if a syringe is undiscovered under under a dumpster or someone that's hard to reach, safety protocols. Again, as I said, we would want to use tongs. But at the end of the day, we don't want people to put themselves at risk by trying to move a dumpster or crawl around on their stomach to get to a syringe. We don't want them to sustain injuries. We would just try our best to access it using clean tongs if we can. And also it's helpful to clean those tongs after use using a part 1 of bleach to 9 parts of water mixture, and that's what's recommended by the CDC to keep those tongs clean as well. And then just a summary, so in terms of preventing accidental needle sticks, as I said earlier, we don't want to handle other people's used sharps. Participants should have access to sharps containers that they can drop their returns in themselves. We don't want to rush exchanges either. That's another point at which things can go awry and people can sustain needle sticks. So even in those busy moments, we want to remain, try and help things to be calm and not to rush what we're doing, and constantly being mindful of our surroundings, especially when we're on outreach, so keeping a good eye out for if we're seeing debris out and about. And if you find a syringe on the ground, you either dispose of it properly as we described, or if it's not your responsibility, is to notify the supervisor or the SSP worker that is responsible for that. I do think that from my experience doing needle sweeps and going out in the community to help remove needles and other drug-using equipment has been a really good way to connect with communities, to build a case for why syringe service programs are helpful. I used to get regular calls from people that in the community that knew we were there, that, if, for example, we had a building site that was being excavated, and they found in one section that used to be a homeless encampment a whole bunch of syringes, and we were able to go in and help them remove those safely, and it was a really great way of educating people in the community and building our community support. And then just in terms of post-exposure protocols, so in the unfortunate event that somebody does sustain a needle stick, what the protocols tell us is that we should wash the needle stick or cut with soap and water and immediately report that incident to your supervisor. And one of the things that I've had to really reassure my staff about as a supervisor is you are not going to get into trouble. Some staff get really worried that they made a mistake, it was their fault, they did something wrong, and we really want to reassure our staff as part of their onboarding and training and regular reviews that it is not, if this happens, you are not going to get into trouble. We want your safety is paramount, and we will follow these protocols to address the situation so that people don't feel like they can't come forward and tell you that they've sustained an accidental needle stick. that they know that it is safe for them to come forward and do so. And then we would seek medical treatment options immediately, and that would include access to PrEP, the post-exposure prophylaxis medication, which makes use of antiviral medications to prevent HIV infection, and it's most effective when initiated immediately after exposure, but must be taken up to 72 hours afterwards, and it's a regimen that lasts 28 days. It only works if the person is HIV negative before an exposure, but getting it immediately can help prevent HIV if somebody has come into contact with that through a needle stick injury. There's no PrEP equivalent to hepatitis C to date, so for the staff that I work to, we helped them get access to Hep C testing, and they were tested over the appropriate period of time to check whether they had acquired hepatitis C or not. So it's really important that we get our staff access to the testing and that it's ongoing testing if they need it. So yeah, getting someone to the nearest urgent care. And another thing that was really important for me on the occasion that this happened, and when I've spoken to other people, is that we don't just send our staff off on their own. This is a really stressful, anxiety-producing situation, so that they actually have a supervisor or a co-worker go with them and be with them while they go through this, and they also receive ongoing support and counselling as needed, because it can be, as I say, very, very stressful for people. But just to reiterate, accidental needle sticks are rare, and if we have a plan in place, as we say, this is the whole purpose of this webinar, is if we have a plan in place, then we're going to help promote prevention and reduce the chances of those needle sticks happening. So I am going to hand over to Hayley now, who's going to take us through the final section of our webinar.
All right, thanks again. And I do want to reiterate for everybody, all these protocols and plans that we went over can totally be implemented in underground programs, street-based programs. I've always been involved with street-based programs, and when we consulted with the Harm Reduction Coalition several years ago about workforce safety and creating an exposure control plan, it seemed really intimidating and like something that was for big professional organizations, not all volunteer-run street-based programs. But turns out it is totally attainable and possible to implement these protocols. The only thing we had to spend money on that we didn't already have were gloves, spray bottles for bleach and water solution, and antibacterial gel. So it's all totally possible to implement these procedures. And so in this next section, we're going to talk about harm reduction, how it's utilized in syringe service programs, some best practices specific to this intervention, and of course we'll talk about the value of syringe service programs in addressing HIV prevention. So we've been talking about HIV prevention for the workers at an SSP, understanding that SSPs are, among other things, incredible HIV prevention interventions. And so in addition to keeping the workers of these programs safe, we're going to talk about how SSPs function overall to reduce the transmission of HIV and other bloodborne pathogens for everybody who engages with them and for all of the communities that these programs situate themselves in. SSPs prevent HIV and other bloodborne pathogens by incorporating HIV testing, referral, and linkage to care, by providing HIV prevention information and condom distribution. That also includes giving out safer injection supplies such as cottons, cookers, tourniquets, and then with condoms, making sure that we have all types of condoms for all types of bodies and all types of people, as well as lubrication for those who aren't able to use condoms or don't want to use condoms. SSPs can also provide education and referral to PrEP, so pre-exposure prophylaxis, which we can use as a tool to also prevent the transmission of HIV for those who may be at risk. All SSPs, regardless of if they're inside a well-funded clinic or if they're an unsanctioned street-based program, we all take part in at least one of these HIV prevention measures. HIV prevention is really inherent to syringe service programs. And we know that using harm reduction to implement syringe service programs is very effective at reducing the spread of HIV and other bloodborne pathogens, but it's also a tool that we use to prevent overdose, stigma, social isolation, and other harms for the people who use our services. We use these harm reduction strategies to reduce preventable and negative consequences that are associated with drug use. And some of those strategies include treating our participants and each other with respect and dignity. We know that for some of our participants, we are the only safe place that they access, and we honor that, and we continue to create a safe space for people, whether it's to just pick up their supplies or whether it's to have a really special relationship with those who are also showing up to the program. We involve our program participants and people who come from their communities in the implementation of our programs. It's really important that we are working in solidarity with our participants and that we aren't just kind of swooping in and telling our participants what they need. We need to have that experience and that background within our programs. With harm reduction, we also recognize the compounding and intersecting socioeconomic inequalities and systems that impact access, engagement, safety, and general well-being for our people. We work to ensure that our services are as low threshold and attainable as possible. So whenever possible, maybe don't ask participants for IDs, because we know that a lot of our folks have trouble accessing IDs or aren't comfortable giving that information. Something as small as that should not prevent people from accessing these life-saving tools. And then we want to be practical and realistic with our participants about the choices that they have and the choices that they can make to stay safe and healthy. So a potential example that may come up while working in the field is that a participant discloses that they are living with HIV and that they're not in care. So some of the best practices that we should follow: first, we should quiet our potential urge to tell that participant that they need to be in care, right? One of the best practices that we can implement is using our active listening skills to listen to them and to ask meaningful questions. So does the person even want to be in care in the first place? We shouldn't assume that they want to be in care. And if they don't want to be in care, why is that? Did they have a bad experience with an HIV care provider? Are they located too far away to be able to access that care? And if they do want to be in care and they're not able to access it, why aren't they able to access it? We try and address those barriers with them, because again, we may be the only person that they trust, and we may be one of their only advocates. If the person doesn't want to be in care, or if they're not immediately able to access care, we can talk about things that they can do right now to stay healthy. So get a flu shot, get the HPV vaccination, eat healthy, drink lots of water, don't share supplies. So again, we can meet people where they're at, wherever they're at. Another best practice that we should use is to adhere to HIPAA. Do not disclose a person's HIV status without their permission. And in general, just respect your participants' privacy. We want our people to trust us, and if we disclose their health information to other people, that's a really quick way to kill trust and give your program a bad reputation. So if there's a need-to-know situation, make sure you've got their permission to share their status. And then safety first. These are some strategies that I've been able to implement at street-based programs, and that we should all be incorporating so that we can keep everybody safe. So working in twos is really important. We're pulling from two different wisdom pools, two different experiences, and it also gives you more dedicated time to talk with participants. So if you've got a really busy program, you can have one person in charge of handing out the supplies, and you can have another person who's available to talk and build relationships with the people who are coming up. It's also helpful. Some of the programs I'm involved in, we've got 4 or 5 volunteers there at a time because we see a ton of people in a really short amount of time. So we've got one person handing out the supplies, one person doing the naloxone training, one person tracking data, and 1 or 2 other people available to just have those conversations with folks. Again, if somebody sprains an ankle, if you're the only outreach worker and you're there by yourself and you trip and fall and hurt yourself, it's hard to get help. So you want another person there so that they can call for emergency services. And you do want to make sure that you don't have more than one person talking to a participant at a time. It can get really overwhelming, especially if those people don't know you. Treat them like a normal person, right? We have one conversation at a time with our people. Again, wearing closed-toed shoes and clothing that covers your legs. Obviously, if a sharp falls and hits you in the leg or in the foot, you're going to be more protected from an accidental needle stick. I've been a part of programs that provide outreach services when it's 120 degrees out, and so there is no way you're going to get any of our volunteers to wear pants in that situation. So if that's the case, make sure that the volunteer who's wearing shorts, who's standing next to the sharps container, is super present and aware of their surroundings. So they shouldn't be on the phone, smoking a cigarette, eating a sandwich while somebody's dumping sharps into the container. Another thing we can do is to not rush, to tell participants to come one at a time, but to make sure that we're not reminding them of their 3rd grade teacher, right? We can ask people to make a line, to be a little organized, but again, we're there as advocates for our people. So we do want to make sure that we're not reprimanding them or making them feel uncomfortable, right? It's really easy to respectfully ask people, hey, it's getting kind of crowded over here. Let's just make a quick line. And then keep a flashlight in your backpack or in the car. If it's dark, if a sharp rolls under the car, you'll be able to easily see it and address that issue. So hand washing is actually the #1 thing that you can do to prevent disease. And really, we're talking about all diseases here that can be easily spread when you're doing outreach or being anywhere in public. So if you're smoking, if you're high-fiving somebody, if you touch a door handle, you share a pen with a coworker, it's not just for food service where it's the best practice to wash your hands before and after work. Hand washing is cheap, affordable, it's simple. We want to wash our hands after disposing of used sharps and other potentially infectious materials, before and after each shift, before eating food on a break, after sneezing, and before and after using the restroom facilities. You want to use soap and water, rub hands together for 20 seconds, rinse, dry. In my experience, we haven't typically been in a place where there's an easily accessible sink. So we've certainly relied on antibacterial gel. Also, we try to make an effort, halfway through deliveries to stop and wash our hands. Or if I need to take a break and get a soda, I'm going to use the restroom in the convenience store and wash my hands. Okay, and then in terms of referrals, of course, we want to be ready with them. We want to have this information easily available, not in a binder in our backpack. Whenever possible, we want to know exactly where we're referring people. Again, we may be the only safe place for people. We may be the only people who they trust. So we want to make sure that we're giving them the most accurate information that we can when they ask about referrals. So it's really important that we know which places are sliding scale, which places take Medicaid, which places are free, because these are really important questions that our participants are going to ask, or information that they're going to need to know. In my experience, we have done some screening of the places that we refer people, just so we know and we can give them the right information. So heads up, you're going to need to have your ID. Just so you know, you're probably going to have to wait outside for 2 hours, so bring water and a snack. And then our people aren't surprised when they get there. So some of the referrals that we frequently make and that many SSPs frequently make are to HIV testing, linkage to HIV care, PrEP, detox, any type of drug treatment, abscess and wound care, STI clinics, food pantries, shelters. We've made referrals for people to get involved with advocacy. We've made referrals for free meditation groups. So our people ask about all sorts of things, and we want to be equipped so that we can give them that information. And then I'm going to hand it over so we can get to the Q&A.
Thank you so much. We've already got a few questions in the queue. So for folks who have questions, use the little blue chat box on the bottom left of your screen. And but I'm going to get going with ones that we already have so far. So one question regarding, going back to Emma's section about the guidelines for picking up syringes. I have two questions for you. One is, can you tell me a little bit about who developed the guidelines for picking up syringes? And two, if you can share what kind of puncture-resistant gloves people might use?
Yeah, so my experience of the development of the guidelines is that they've been based under the guidance of the OSHA recommendations and exposure control planning, but obviously, you know, as I said earlier, we're not the same as a hospital where a lot of these guidelines were originally developed for, or medical centers, so we took them and adapted them with the guidance of, you know, the right people who work in the medical field to help us develop those. So, and as I say, it is different. Like my program, we had to have tongs. That was the part of our state guidance and state funding to be able to provide syringe service programs. But, you know, depending, you must make sure that if the tongue, you use tongs, that they are secure and they aren't the type of tongs where the needle can actually easily flip out of the tongs and then end up sticking in someone's leg. So that's also where some of these guidelines are developed, where, like, if you haven't got access to tongs, we still don't want to leave those shots out there. So, you know, we were able to develop under the guidelines, you know, recommendations of how to pick them up using gloves, and you know, picking them up by the barrel and putting them in the sharp point down. So that's my experience. I don't know if Haley's got any additions she would add to that. And then in terms of the access to the puncture-resistant gloves, there are various places that produce them, and what I can do is, we had a really great connection with a guy that specially designs them, and he gives, you know, good prices for people. I can definitely send that information along to be shared with the webinar slides for people afterwards if they want a contact of where to get the actual, they're usually black puncture-resistant gloves that people also use, especially when they're out. We use them out on mobile outreach versus just using the rubber gloves or the latex gloves.
Thank you so much.
Yeah.
So as we wait for a few more questions to come in, I'm going to turn it over to Adrienne to talk through the technical assistance that we provide and then some recommended resources. And just for folks who are wondering if you're going to have access to these slides and recordings, yes, they will be on AIDS United's website later today or early tomorrow, aidsunited.org/webinars.
Thank you for that, Sarah. So for everyone who is on the call, if any of this information resonated with you or it helps you to think about how you could better build your capacity, please feel free to reach out to AIDS United's Getting to Zero program for capacity building assistance. we are definitely happy to be partnering with not only the Harm Reduction Coalition, but also the Bridging Group to be able to provide a lot of TA or capacity building assistance to your organizations. And so, as I say in the beginning of this webinar, our main goals are to strengthen HIV prevention efforts among people living with and at high risk for contracting HIV, organizational and program development, best practices to improve impact and sustainability, and we also offer some evidence-based interventions, specifically Willow, Project Start Plus, and Healthy Relationships. So if at any moment anyone on this call, on this webinar, is in need of capacity building assistance, please feel free to reach out to us via email at ceba@ageunited.org, or you can go to the Age United website to easily find us and pose any other questions. And then I'm going to speak a few minutes on recommended resources. So as it relates to the Harm Reduction Coalition, they do capacity building specifically as it relates to syringe access tools and policy and advocacy. Age United, we have tons of syringe service information for you, specifically as it relates to improving the health of people who use drugs, securing the link, which is a guide to support individuals returning to the community from jail, and then Syringe Access Fund, which is a grant opportunity for those who were not on the call or on the webinar at the beginning. Grant making is one of our pillars, and so if that is something that you're interested in, please feel free to visit our website for those opportunities as well. And then a few websites that you can visit on how to develop an exposure control plan is cdc.gov. You'll see that that's the first link on the page that you are seeing right now, and then we also have resources for preventing needle sticks and sharp injuries, sample exposure control plans, and the OSHA webpage about universal precautions. And again, I will repeat, if any moment you need help with looking up resources or need help with any technical assistance at all, please feel free to reach out to not only Age United, but any of our partners, the Bridging Group, as well as the Harm Reduction Coalition.
Thanks, Adrienne. So we've got a few more questions in queue. This is one going back to about the soda bottles. The participant is asking, does Emma recommend having the participants transfer their syringes from a soda bottle into a sharps container? Isn't additional handling to be discouraged?
That's a great question. I'm glad you asked for clarification on that. No, we're not asking people to tip the syringes out of the soda bottle. What we did was we actually took the soda bottle and then put the soda bottle into the a larger sharps container. So again, if you're doing outreach or you've got people coming to your program that may be bringing those kind of their own household containers, you want to make sure you've got the really big, we have like 8-gallon size sharp containers that they can then put the soda bottle into. We're definitely not asking people to uncap the soda bottle and tip out the syringes into the bucket or the safe disposal container. We're actually putting the whole soda bottle into the container. Hope that clears that one up.
Thank you. I'm going to direct this question to Haley. Other than providing needle cleaning kits, what suggestions do you have for agencies working in states that prohibit needle exchange?
Yeah, that's a great question. I'm currently in a state that prohibits needle exchange. We have been able to work with stakeholders at various levels to actually implement programs with law enforcement and specific county support. If you're not in a position to be able to do that, there are other supplies that you can potentially give out, such as cookers, cottons, antibiotic wipes, everything but the syringe, where we can also transmit HIV, Hep C, and other bloodborne pathogens. Also, if you can find places where participants hang out, so they may be coming to your overdose prevention program, they may be hanging out outside of a clinic, they might be hanging out in a park. That's a really good place to just start conversations with people. So if you're handing them a kit that has everything but the needle in it, if you're handing them an overdose prevention kit, start the conversation. Ask them what they know about HIV, Hep C, and other bloodborne pathogens. If your agency does rapid testing of any of these pathogens, that's another great way to start the conversation. And regardless of whether the person screens positive or negative, we can give them useful tools to prevent the transmission of those pathogens. So there's still a lot of creative things that we can do even if we aren't able to have sanctioned syringe services programs in our regions.
Thank you, Haley. We've got a few more questions in queue, and we definitely have time, so if you have questions, please feel free to keep putting them in. These are really great questions. Is there a process for training volunteers on how to safely pick up and dispose of sharps? I'm leaving that to either Haley or Emma, whoever wants to answer that one.
Haley, do you want to talk about, like, we actually came and trained you around setting up your exposure control plan. HRC came out to train your outreach staff. How did you then take that to train them out in the field?
Yeah, so we were super grateful to have HRC come out and do this training and make it really tangible for us. A lot of the tactics that Emma brought up, it can be super simple. We prefer to use tongs whenever possible, and then picking it up on the barrel end. So I sat down and created this in-depth exposure control plan with Joanna from HRC, and then we presented it to our volunteers, and we went over some of the strategies, and we had a lot of questions come up from the volunteers that we hadn't initially thought of. So I think it's really important to get that buy-in and to make sure that we're addressing all of the possible situations that could come up. Whenever we bring on new volunteers, we do strive to include this in the volunteer orientation about how to handle sharps if they're outside of the sharps container. It's our policy that we do not touch people's sharps containers. We've actually had situations where the person's container was too big for our sharps container, and we actually had to turn the person away and tell them that we weren't able to take it because we have experienced the needle stick. We've actually experienced 2 needle sticks before we had this exposure control plan, and so that's why it was so important for us to create these policies. Yeah, super simple. I think that the best way to do it is immediately when onboarding new volunteers or staff to go over it for 5 to 10 minutes with them about how you should and shouldn't be handling other sharps. And we're actually getting ready to do our annual review. We've got a lot of new volunteers and resources have changed in our city. So we're about to go over our exposure control plan again.
Thank you. I have a follow-up question for that just came in. How comfortable are you with training volunteers on site to assist on the same day? So would you provide training on that same day, or would you do it earlier and ask them to come back at a later time after it's fully sunk in? I think is what the question is asking.
Yeah, we're totally comfortable doing it the day of. And actually, I think that it can be easier for people to grasp when they actually see. It's no longer a theory, but they're seeing people show up with containers. They're seeing people dump their used syringes into the sharps container. I think it's totally fine as long as you have all the materials on site that you're going to need. So make sure that you've got access to hand washing or antibacterial gel. Make sure you've got gloves. Something that was that ended up being really important for us that one of our volunteers brought up was the potential blood that could be on the outside of a sharps container, because we've got dozens of people touching the sharps container. People have cuts on their fingers, etc. So we have that bleach bottle so that we can spray off the sharps container before we handle it. I know I've always got hangnails and cuts on my hands, so that's really important. But absolutely, I think that this information can be conveyed in 5 to 10 minutes. And I do think that at least once a year going over the overall plan doesn't have to take more than an hour, but it's easy to get people onboarded with this.
Thank you.
Yeah, I'd agree with Haley. When we had new folks come and join us, you'd train them. You could train them at the site, and then maybe have them observe the other staff for a while, and the other volunteers, so they could be maybe giving out sterile supplies, but then have them just be available to observe how things are going on, so that they can very quickly pick up what the requirements are in order to keep themselves safe. So yeah, I'd agree with that.
Great. We have a follow-up question about the sharps containers that someone might bring in if it's not a traditional sharps container. What should you do if someone brings in a non-recyclable container?
So I'm going to go first, and then I'm going to ask Haley as well from her experiences. It is interesting. People will bring their needles back in all kinds of different containers. As much as possible, we would, if they would fit into the red sharps containers, we would put them in there. So that, to give that, as I said earlier, to give that extra level of protection. I mean, basically, the experience I had is, even if what they were bringing them back was non-recyclable, they go in the red sharps containers and they go off to be incinerated. But if something's too large, like Haley said, or it's just not going to work, what you can do is, very rarely did I have to turn anyone away, but just ask them to go in, come back and bring them back in something that they could. Dispose of them in, making sure we give our participants sharps containers, the actual sharps containers that they can take home, and having various sizes of sharps containers can be really helpful to help minimize that happening. And then if people brought back things like, they were secured them in thick detergent bottles or bleach bottles, we would also have the red biohazard bags if it was safe to put them in those bags if they were secure enough to then send those off with the bins to be incinerated. So that's a couple of things we did on my exchange. Haley, anything additional you've had experience with?
Yeah, we've had people show up with containers that they didn't want to get rid of. So they might have a metal box where they were keeping all their supplies, and they wanted to keep that metal box. So we would have them dump them out, but we'd make sure that everybody was standing far enough away so that if a sharp fell on the ground, it wouldn't poke anybody. And then we'd just talk to the person before they were going to dump it out and say, listen, if there are any sharps in here that aren't yours, we need you to be really careful. I don't know if that's the best practice, but it's worked for us. We haven't had anybody injured. We have certainly had a couple sharps that fell out of the container, but everybody was standing far enough away, and we had our tongs to be able to deal with it safely.
Thank you. So we don't have any more questions. Oh, wait, we just got another question in queue. If you are on outreach and say someone has a soda bottle, but you do not have, oh, you know what? You just answered this question, but maybe you can just reiterate how you would handle something that is too large to fit in one of your sharps containers.
Yeah, if the person, if it's only their sharps, and they have indicated that they can dump it into a smaller container, that's fine. Actually, in our state, when we call the State Department of Health and the Department of Environmental Quality and tell them that we've got sharps that we need to dispose of, not necessarily on the syringe service program, but if you call and say, hey, I found a needle on the street, what do I do with it? They actually advise that you put it in a hard plastic container, write biohazard on it, and stick it in the trash. We don't have a lot of sharps disposal resources in our state, so we will also advise people of that. Because of many of the laws around paraphernalia, a lot of our participants are too afraid to bring back their used syringes because they can be stopped and arrested and charged with possession of a substance, even if just the residue is in the syringe. So we do give people resources so that they can dispose of those sharps as safe as possible on their own.
And just to piggyback off another idea that has come up in a couple of other exchanges that I've been in contact with, the staff actually collect their bleach bottles and detergent bottles, and if participants don't want to take the sharps containers because they're too obvious, but they do feel more comfortable to take the detergent bottles, they'll take those with them. So that's just another additional thought that came to mind as we were discussing those points. So if people, that's something, another strategy that people have used to encourage people to, dispose of their sharps safely. And like as Haley said, that if they're too scared to bring that detergent bottle back, you can educate them on how to seal it, label it, and put it in the regular trash, because we have the same considerations in New York where I worked as well to be able to do that. So that's another tip you can give to those participants that might struggle to bring their syringes back to the exchange.
And I will jump in one more time. when, we'll ask people if they have sharps to dispose of, and if there's a day where we're hearing a lot of people say that they don't have any to dispose of, that they dispose of them on their own, we use that opportunity to ask them, okay, so how are you disposing of them? And we find that oftentimes we miss people and we aren't able to give them information about, locating those laundry detergent bottles or bleach bottles and sticking them in the trash. So that's an opportunity where people tell us, oh, I break the tips off and I flush them. And then we say, well, the tip is the part that's the really scary part. And if it's not attached to a barrel, there could actually be more risk. And we've got sewage workers. And so would you consider sticking it in a sharps container? Would you consider putting it in a biohazard or bleach bottle? So I think that's a really important way to get information from your participants about what they're currently doing and brainstorm with them about ways that they can safely dispose of their sharps that work in a way that's appropriate for them.
Thanks, Haley. We have a few questions relating to mobile exchanges. One is, are there any extra safety concerns that should be taken into consideration for a mobile exchange? And then two is, can you talk a little bit about best practices for a location to do mobile exchange and how to do crowd control and what extra equipment you might need to bring?
I can speak from my experience, and then if Haley wants to add. So I think for me, doing mobile exchange is definitely being about like where you're placing your containers. Often at building a fixed site, you've kind of got places where you can build out a safe corner or a safe area to have your sharps containers. With mobile syringe exchange, you need to be very mindful of where's the point you're going to put them at, and what height you're going to have your container at for easy access, depending on the type of vehicle or where you're located on the street. We try to secure an area on the entrance to our vehicle rather than just having them on the street where they can tip over, where it was secured and people could then access a height that was also where they're not bending over to try and put things in. And then for me it was also, like I said earlier, about making sure that when you're in transit and you're transporting those containers back, that they are very well secured and that you've got enough things to secure them. We used to have a special area at the back of the van which was designated especially for when we were driving so that it was easy to secure them so they wouldn't tip over, and we had bungee cords, extra bungee cords to help them, stay upright and stay secure because the streets in New York they're not very well looked after, so there's lots of bumps in the roads. Haley, is there anything you'd add from your experience?
Well, addressing the question about crowd control at a mobile site, so we work with a program called Shot in the Dark here in Phoenix, and they'll see 400 people in 2 hours. They post up in parking lots, they go to parks. All the areas that they go to are completely informed by where the participants ask them to go, and they do target the hot spots, which it was really validating to see. Recently our state came out with data about where some of the opioid use hotspots are, and those were exactly the places where Shot in the Dark already was. So good to know that they're listening to their participants and that's accurate information as reflected by the state. In terms of crowd control, though, so 400 people in 2 hours, that's a big crowd. Again, having as many volunteers there as possible who are all on the same page. They do an assembly line. So they've got one box that's full of needles, all in packages, of course. They've got one box that's full of alcohol wipes, one box that's full of condoms. They've got a person on the end doing overdose prevention education, another person on the end doing referrals. So it's very clear where people should start. And as long as you've got that rapport and perhaps new participants see that the existing participants respect you and have those relationships with you and that you respect them, crowd control really hasn't been an issue. And then with extra equipment, The sharps containers, a lot of times we encourage people to bring multiple sharps containers. If you don't have a whole lot of room in your car, you can stack the sharps containers so it doesn't have to take up a whole lot of extra space. And then, our sites do often run out of supplies, so we really try to ingrain it in the culture to always bring more supplies than you think you're going to need. Bring more than you brought last time so that we don't experience a shortage.
Thank you so much for that, Haley. So we know that we have some questions that are still coming in. Unfortunately, due to time, we won't be able to get to all of them, but I will encourage you to contact us here at AIDS United, or feel free to reach out to the Harm Reduction Coalition or Sonoran. But at this time, we do have to move forward in the webinar. AIDS United would like to acknowledge our partners, the Harm Reduction Coalition, along with Sonoran Prevention Works, for their leadership and content development and delivery of this webinar. Surely without our partners, this would not be feasible. So we definitely appreciate them for lending their expertise as it relates to this webinar. Also, I do want to encourage everyone to be able to stay on a little bit longer after we end the webinar to fill out a brief evaluation. This will allow us to really make sure that the content that you received today was beneficial and that you were able to get some key information that will help you be successful in your efforts in the future. And so I'm now going to turn it over to Emma to talk about the Harm Reduction Conference.
Thank you, Adrian. Yeah, so as I said at the beginning, we have a conference coming up in New Orleans in October from the 18th to the 21st. So we would encourage as many of you as possible to try and come and join us. Our last one was in San Diego. It was the biggest one we've ever had, and we had people come from all over the country, from lots of different organizations and agencies, talk about harm reduction and how we can incorporate that into our programming, and that included social workers and housing providers as well, not just syringe service program providers. So it's a great place to network, and it's a lot of fun, and it's in New Orleans. So start talking to your supervisors now to get approval to attend.
Thank you all. And to the operator, I believe this is the end of our webinar. So we will end the meeting, and you will get a link to complete a survey. Thank you so much.
And again, that does conclude today's webinar. Thank you for your participation.